posteriorly it has superior colliculi. So midbrain is basically for control of the eye movements, right? So control of eye movements. For example, if a patient comes to us with hydrocephalus, so this thalamus and the ventricles sit right on top of the midbrain. And if there's increased pressure within the ventricles, what happens? It puts pressure on the midbrain as well. And these patients then have setting sun sign. If you should just look into it, right? So these patients are unable to look upwards because the midbrain is responsible for the movements of the eyes. If there's any pressure in the midbrain, the eyes will not move in a particular direction. So it is completely different from extraocular movements, which are controlled by the different nerves which are part of the prefrontal nervous system. This is part of the central nervous system. Moving downwards from the midbrain, we have the pons. What is the function of the pons? What is the function of the pons? And this is a very important structure over here, which is regulating how a patient wakes up and how a patient sleeps and how the reticular formation, right? So the reticular formation is over there as well, and obviously every track goes through the pons and medulla, right? How do we differentiate pons from medulla on dissection? क्योंकि ये चल ही नहीं रहा. अच्छा अच्छा हाँ मेरी आवाज़ वैसे ही बहुत कम आती है. If you guys can just move a little bit forward, if it's possible for you, so that my voice can reach at the back as well. आ रही आवाज़? आ रही? I guess नहीं आ रही. अच्छा, so pons, medulla, and the critical thing about pons and medulla is that they are very important nerves that are arising from this area, right? So what are the nerves that arises from pons? Third, fourth, and so the third nerve is over here. So in lesions which are just below the thalamus, third nerve usually gets involved. Sixth nerve is from the area of medullars, not really the abducens nucleus is somewhere in between pons and medulla, but the nerve crosses just beside the pons, right? So the sixth nerve, the fifth nerve, all of these, they arise in this area, and some very important nerves like these nerves over here. This is a trigeminal nerve, it's a very thick nerve. So it just leaves at the border of pons and medulla, and then in between we have a whole bunch of nerves. This is 9, 10, 11, right? They all arise together, and this one at the back is the 12th nerve, right? So very important critical structures are around the brainstem. How do we divide these? Is we divide the brain into two compartments, the supratentorial compartment and the infratentorial compartment, and based on the location of the tentorium cerebelli. Everything above the tent is supratentorial, everything below the tent is infratentorial. Infratentorial compartment has brainstem, fourth ventricle and cerebellum, right? And infratentorial compartment usually the tumors or the lesions in the infratentorial compartments usually have worse prognosis than the ones in the supratentorial compartment, right? So let's talk about cerebellum. Cerebellum is a structure, it's a very complex structure, but basically it controls fine motor movements and balance. So balance and fine motor control. It has how many parts? We have a central part which is called the vermis. We also have bilaterally we have two cerebellar hemispheres. Inferiorly we have uvula, we have tonsils, we have other structures as well. All of these structures, the basic control they do is coordination, balance, as well as fine motor control, right? So if anything happens to the cerebellum, the patient usually has tremors. He cannot do fine work, he cannot close the shirt, he cannot balance himself while walking, right? So everything goes through the cerebellum. Where is the fourth ventricle? The fourth ventricle is just, I don't know if you can see it or not, it is just between the cerebellum and the posterior part of the brainstem. So somewhere over here is the fourth ventricle. And why am I mentioning this? Because fourth ventricular tumors are very common. And if there's anything which is blocking the fourth ventricle, the patient will have hydrocephalus, right? So far, is there anything else that you don't understand regarding the neuroanatomy? Because I just want to keep it simple. I don't want to go into too much detail. Anything that you want to ask regarding the anatomy and critical structure? So let's review it a little bit. Superficially, we have the brain cortex. We have two cerebral hemispheres which are connected in between through the corpus callosum. And then we have four lobes in the cerebral hemispheres, which are frontal, parietal, temporal, and occipital. We did not talk about temporal lobe. Temporal lobe is a very important lobe. Temporal lobe is basically for speech and hearing and memory formation, right? So if patients have seizures which are involving lesions in the temporal lobe, they are usually complex seizures which are associated with different types of smells, auditory hallucinations, right? So it is a very, very complex organ. And in the medial side of the temporal lobe, you have hippocampus, you have amygdala, you have all these critical structures, right? And you also have basal ganglia in that area. So temporal lobe is laterally, frontal lobe and temporal lobe are separated by Sylvian fissure. Whereas Wernicke's area, we talked about the speech area, the Broca's area, which is in the inferior frontal gyrus. So basically on the bottom of the frontal lobe, somewhere where the temporal lobe meets the frontal lobe. Where's the Wernicke's area, which is the language area. Whereas it is at a junction. So Broca's areas, it is somewhere between temporal and frontal lobe, basically inferior frontal gyrus, right? And the Wernicke's area is somewhere between temporal lobe and parietal lobe. So where the superior temporal sulcus, where it just bends upwards, that whole area is Wernicke's area, especially on the left side. If you damage on the non-dominant side, you will not have any issues. But if the Wernicke's area or the Broca's area is damaged on the dominant side, the patient will have symptoms, right? So eloquent areas basically for speech, and you have to save them at all cost. Okay, so and how is the frontal and parietal lobe divided? Through Rolandic fissure or the central sulcus, right? And central sulcus, anterior to the central sulcus, we have the motor cortex. Posterior to it, we have the sensory cortex. So critical area, all of that. Okay, and if we go deeper into the brain, in the midline, which structures do we have? Superiorly, we have the two lateral ventricles, and just on the in between the two lateral ventricles, we have the corpus callosum. Just superiorly bending upwards through the lateral ventricles, we have the corpus callosum. And then if we go through just below the lateral ventricles, we have a single third ventricle, and on both sides of the third ventricle we have the thalamus, right? And then on lateral to the thalamus we have the internal capsule, and lateral to the internal capsule we have the basal ganglia. Critical structures, again eloquent areas, we did not touch them. And then when we go down from the third ventricle, we will have, or let's say just below the anterior part of the third ventricle, we will have the hypothalamus and the pituitary gland, both of them, right? And then just below the thalamus, we have the brainstem. So midbrain, pons, midbrain, starting in there, and all of these things are in the midline. Laterally, we have critical structures as well, but in the midline, we have structures that we have to, like for example, if a patient has a brainstem lesion, we will not operate it on most of the cases unless the lesion is coming out of the brainstem. But if it is within the brainstem, we avoid surgery at all costs, right? So, any other question that you want to ask regarding anatomy? Because you will start brain dissection, and once you start brain dissection, these are the structures that you will have to identify. Right, so brain dissection, the first step would be to observe the specimen, right? So overall, you will observe what you're seeing. There are different layers above the brain, right? We have the three meninges, which are starting from outside to inside. We have the dura mater. How does the dura mater show up in? आप लोगों के specimen में dura तो नहीं होगा ना? तो उससे brain है. meninges है उसमें. So the topmost dural layer is a whitish layer which is very, very visible. I don't know if you guys have ever seen a dura in real life, but it is a proper white layer covering the brain. Once you've opened the dura, there are two layers which are on the surface of the brain, right? And there's a glistening whitish layer. If you do proper dissection, there's a glistening whitish layer in which you can see the vessels going through that layer as well. That is a subarachnoid layer. Sorry, arachnoid layer. And the vessels in between are in the subarachnoid space. And once you remove that layer, you cannot really see pia, because pia is very tightly adherent to the cortical surface. So we assume the cortical surface has pia on it. But you can identify arachnoid membrane, you can identify dura mater, right? But the pia is tightly adherent to the brain, right? So once you have started dissection, there's a glistening white shiny layer on top of the brain. That is the arachnoid layer, glistening shiny. The white layer, dura is completely separate from the brain. It is not adherent to the brain. It's like a covering. Like if you put a ball in a sock, the sock is the dura and the ball is the brain. So it is completely separated from the brain. It is not adherent. Pia and arachnoid are adherent to the brain surface itself, and you cannot see pia. Arachnoid is a shiny white layer spreading on top. It's like a jelly type layer on top of the brain. And dura is a white layer which is separate to the brain. It is a proper layer. It's like you can properly see it's a completely different thing from the brain. right? And pi you cannot see. So once you have a brain, once you start your brain dissections, look for the arachnoid layer, look for the subarachnoid space, which is identified by the vessels on the surface of the brain. And then once you've dissected through the arachnoid layer, you will reach the brain surface, the cortex, basically. The upper 2 to 4 mm is the cortex. And then if you go deeper down, like the gyra and sulca, right? And once you go deeper down, you will reach the white matter, which are the tracts. And then you'll see all these different structures. On surface, I want you to identify during your dissection practice where the central sulcus is, right? And where the longitudinal fissure is, where the sylvian fissure is, and how do you divide based on anatomy which part is the frontal lobe, which part is the parietal lobe, which part is the temporal and the occipital lobe. And then you can go deeper into the dissection and then identify the internal structures. Internal structures are not like this. You will not be able to identify as properly as you see over here, but you will have some idea how it is. Okay, any questions? Any questions? Thank you. बहुत अच्छा है, थोड़ा बड़ा होना चाहिए।
So thank you, Dr. Abel, for this beautiful lecture. I think सबकी jot up हो गई होगी memory for the neuroanatomy. Now Dr. Farrukh would perform the brain dissection. It will go live on the projector, तो आप लोग seated रहेंगे. आपको सब Dr. Farrukh यहीं से guide करेंगे. We'll do the setup just 5 minutes. You can talk or do something.